Our next speaker is Dr. Robert SIDONIO Jr., and he's actually going to be joining us virtually. I think he's on the line. Michelle? Michelle? Is Dr. SIDONIO on the line? Yeah, all right. So he's joining us from Emory University in Georgia, and his talk is entitled Joint Health Status in Women with Bleeding Disorders. Thank you so much for joining us today, Dr. SIDONIO.
Yeah, thank you, everybody. And sorry, I wish I could be there. I feel like I've been traveling a lot. Certainly love to come visit my friends in Canada. So the task that I have today is going to be talking about joint bleeding and the issues associated with it. And we'll show you the objectives here. And so this is a difficult topic because we've done a relatively good job in the last decade or so of getting to the issue. But it's sort of stalled on what do we do next, and I hopefully that's a part of it. And so I'll be able to describe the prevalence and sort of give you an understanding of what happens with joint bleeds. But unfortunately, we don't have a lot of strategies, and there are not a lot of prospective studies looking at how we could do this. And so that's where obviously they'll be open for discussion. Just to make sure we're all on the same page, and when I give these talks, there's always a lot of concern and outrage about how we're not doing enough, but I think it's important to understand the volume of patients that we're talking about. So we know that based on the CDC data from the Universal Data Collections Project and from CDC Community Counts, there are a number of patients, about 1 in 5 mild hemophiliacs is female, and when I refer to this means assigned at birth or transitioned. And so you can see here, the number of those with severe disease is very small. We likely collect most of those patients. It's very unlikely that we're missing those. So we're talking about 51 patients in the entire United States. When you talk about moderate patients, it's another additional 80, and maybe there's some out there that aren't collected, but largely they probably are collected. And then in the mild, utilizing the WFH definition of 40%, it's about 1 in 5. If you go up to 50%, it certainly is a higher number. And certainly we're probably not capturing everybody. We know that there are a number of carriers out there, at least 4 possible carriers for every male that's affected with hemophilia. At least 1.5 are definite. And then we know at least a third of those have levels in the hemophilia severity range. And then there's lots of bleeding that occurs in hemophilia carriers. It's been described very well by Dr. Paula James. A number of groups have done this. It's been summarized in a recent paper by Connie Miller, who worked at the CDC, but dental extraction bleeding, surgical bleeding, postpartum bleeding, and certainly the one that we're going to talk about, joint bleeding. It's a happy uterus there, but this should be heavy menstrual bleeding. And then nosebleeds. I couldn't find a picture with a woman with a nosebleed, so I had to use this picture. But obviously the one that we're going to focus on is hemarthrosis, and that's what the topic of this title or the talk is. When we did the study, we looked at a number of patients at Vanderbilt University in Nashville. We compared definite carriers, genetically verified. We had their levels, and we did an extensive hemostatic and thrombophilia evaluation. And made sure that there was nothing else that was going on other than their bleeding disorder. And then we compared it to normal women. These were women of children with hemophilia, with leukemia, because I had access to this in a peds hemonc clinic. You can see there in the blue bars, number of patients with bleeding across the board. But obviously the one that was the most interest was hemarthrosis. So almost 20% of the women had reported at least one joint bleed. Some of them weren't sure, so we didn't document it. When we look back at this, most of them reported maybe 1 to 2 in their life, and these were mostly women in their mid-30s. And so we were able to get from the CDC the joint range of motion study. So this was done with nurses and physical therapists. They collected the joint range of motion that was detailed and taught to the people at the centers. They collected these all on the men, and then they also happened to collect it on the women that were included. This group of women that were added to the CDC was actually not studied and was not, it wasn't data that was rejected, but you actually had to write in that they were a carrier. And so some of them, we didn't know if they had hemophilia A or B. But certainly what we found was when you compare to a normal joint range of motion, which is listed there in the dotted line at the top, there was an accelerated loss of joint range of motion in women with hemophilia. As you can see on the moderate and severe, it gets a little bit dicey because many of these women had passed away from HIV and hepatitis complications. So we've done a couple of other studies. We decided to do a chart review looking at our experience. So 47 patients. These were hemophilia carriers at centers and those with and without deficiency. With factor deficiency, these were done at 3 hemophilia treatment centers. And you had to have at least 2 clinic visits. You had to have some documentation of these bleeds. So certainly there are more bleeds that are happening than this. And this was collected from 2012 to 2015. And you can see the number of centers and authors involved there. There were 23 women and girls with what they called factor deficiency that experienced some form of joint bleeds, whether that was traumatic, spontaneous, and 9 of them had joint bleeds. And you can see the distribution of the bleeds there as expected in the ankles and knees as well. And surprisingly, some in the elbow, which would not have expected as much with mostly mild deficiency. We worked with Christina Haley and Shirley Abram with Athen. I think Peter Coates called this project Athena, so we went with that. This is the organization that collects data along with the CDC, and we wanted to just look at a snapshot of how many patients have some evidence of joint disease. And you can see here in the hemophilia carriers and women with hemophilia, the joint rate was around 10% or so. The overall joint bleed rate was about 8%. So that includes those with Glanzmann's, Bernard-Soulier, and rare factor deficiencies. And we'll get back to von Willebrand's. I sort of separated it out on this. One of the more interesting studies that was done in Sweden is they collect this data. They have a pretty good documentation of their women with hemophilia. And they were actually able to look at their outcomes over a 22-year period. And Jan Ostermark was the senior author on this one. And you can see the breakdown here. I love this graph because this is sort of what we hypothesized, that it was a nice normal distribution. And that's exactly what you got, around 50%. And normal women, you can just shift that curve over to 100%. But you can see here, they identified 50 women with factor levels less than 40% and compared that to those that had levels consistently above 40%. And what they found was that when they had deficiency, you were 2 to 3 times more likely to have some documented joint bleeds, either diagnostic codes or documentation, and then 10 times more likely to have some joint surgery in the future. We don't know if it was related to it, but certainly joint surgeries are not extremely common in a relatively young population. And so at least there's some long-term outcomes that are seen and sort of points to the relative deficiency leading to some hemarthropathy later. So a lot of meetings I go to, people say, well, what do we do about this? Well, I think we need to look at what are we doing with males with hemophilia, right? And we know that non-severe hemophilia A males, it constitutes about half of the patients in the United States. This is from the Athen data set a few years ago. I went back and looked and see who are the patients that are on prophylaxis. So I don't know what the numbers are in Canada, but at least 10% of the mild hemophilia A males were on prophylaxis at some point in their first 18 years of life. And you can see that from evidence on here. And then when you look at those with moderate hemophilia, it's at least half of the patients. And I think in 10, 15 years, the majority of those patients will be on prophylaxis because all of the therapies have basically made the severes non-severe and more like mild. And so I think it's something to think about. What are we doing with the males that have this long-term damage? And is there something that we can learn from them? And so, not completely connected, but certainly related. We did looked at medical claims data set. This is Divya Sridhar, who's at Arkansas, who's been doing a lot of this data. And we have some interesting data that will come out related to reproductive tract bleeding and use of IUDs and spontaneous and medical abortions. And so look out for that paper. But we looked at this aggregate of electronic medical records from 26 major healthcare systems, 360 hospitals, over 72 million unique patients. And we wanted to isolate those that have von Willebrand's and carriers. And what we found was that osteoporosis, osteoarthritis, and rates of fractures were at least twice as common compared to the female controls. You can see there's a lot less carriers involved. And part of this is that you can't separate out the different severities, but certainly there's a trend to show that, bony outcomes, joint outcomes, I just showed you, are worse in this population. And so we need to come up with some strategy to mitigate this. And wanted to give a shout out to Dr. Scholzberg, who will be looking a little bit closely at this in a prospective manner, targeting those symptomatic carriers and looking at bone mineral density over time. So we'll all eagerly await this data. So the question comes up, what do we do about this? Well, certainly joint range of motion is reduced, similar to those that have mild hemophilia in males. We know that those are less than 40% are at risk for joint bleeds. And so the question always comes up, what can we do? And it's not really clear whether prophylactic factor can prevent this. When most of these patients are reporting less than 2 or 3 in the first 20 to 30 years of their lives. And so is the intervention of doing prophylactic factor, is that worth the administrative burden of that to prevent a few events in the future? And obviously, as our therapies get better, it certainly will be, but it's a question at least we have to ask the patients, are they willing to put that much administrative burden up front to prevent those events later in life? And it's something that we need to talk about. We don't really put a lot of our males with mild hemophilia on prophylaxis. Certainly the ones before age 18, if they're very active, I think it makes sense. So there has to be some sort of altered regimen that we could consider. And the problem is trying to do a study on this is very difficult, right? I mean, you're going to have to study over 5 to 10 years probably to see any difference. And I don't know a lot of funders that are looking to fund studies over a decade. So, but certainly think about this. What I tell the patients oftentimes is if there isn't any clarity in this, get a joint ultrasound, get a plain film. If there's blood in that joint, you can see it on a plain film typically, compare it to the contralated side. And I think what we need to do is encourage people to better document the bleeding, because when they come to the clinics, they may demonstrate this or say they've had it. And, it obviously has much more power if there's radiologic demonstration. We know that hemophilia isn't von Willebrand's, and the topic I know covers all bleeding disorders, but there's very little data outside of von Willebrand's and hemophilia. And, there's overall issues with the number of trials in von Willebrand's, leading to a lot of variability, frustration. There was the effort that Paula James just mentioned. But, we obviously need more data if we want to have stronger recommendations. Generally, women often are misrecognized, and it takes quite a long time to recognize whether they have a bleeding disorder. When you look at the ones with relatively mild deficiency, when you look at females, generally heavy menstrual bleeding is the most common, and then nosebleeds are the most common in men or presenting with bleeding from a procedure, which isn't that surprising. But certainly when somebody asks me about this, oftentimes the bleeding is significant. It takes up a lot of our healthcare dollars, and interventions will definitely be cost effective. We have to recognize that there's gender-specific bleeding symptoms in the presentation of severe von Willebrand's. And those with males, they typically present with nosebleeds and hemarthrosis. And in women, heavy menstrual bleeding and nosebleeds become a lot more common than we see in milder deficiency. The other thing that we need to recognize is there's a large variation in bleeding scores. When you look at them, no matter what bleeding score you use, there's a pretty large variation. I mean, you can see the scores for those with mild von Willebrand's can be as low as 0 and as high as 24. You don't see as much of a spread in those males. Certainly there are smaller numbers here, but it's something to at least recognize as one of the challenges. And I showed you earlier this project, the Athena project, which we have some additional data we'll show at ISTH. And so, when we look at those with von Willebrand's, the hemarthrosis rate is about 10%. And so when we look at this over time, and this is an older paper by Tom Abshire, we know that there's an accelerated loss of joint range of motion, certainly much more in those with severe disease, type 2A, type 3, more so than type 1. But what's really interesting is that you see range of motion loss in the hips and ankles. It's not a typical location that you would expect to see, particularly in the hips. But you see that as the leading locations, ankles and hips. And so just something to recognize, and probably need to pull some additional data from CDC community counts, since this data is over a decade old now. Karen Von Galen has done some nice data looking at post hoc analysis of joint outcome data. And when she looked at comparison to hemophilia, you see the HJS scores are elevated, and joint bleeds are reported in 23% of those with moderate to severe von Willebrand's, levels less than 30%. They typically start in childhood. They are associated with clotting factor use, joint pain, and lower scores. And what's interesting is even though they're lower scores, they lead to the similar amount of long-term damage. So again, maybe we're not recognizing these joint bleeds and von Willebrand's, and we're not advising. And then the final couple of slides, again, when we looked at bony outcomes, you see the rates are at least twice as more common: osteoporosis, osteoarthritis, and fractures in those with von Willebrand's as well. And so certainly we could do better. And one of the questions that comes up is, what can we do? And we know joint range of motion loss is happening, that women are at more risk for bone and joint health outcomes. And again, we don't know whether factor is going to prevent this. We hope it is. And again, it's difficult to come up with a design. And so again, we want to make sure people are getting imaging on this, documenting it. And I think we all have to get together and figure out, how are we going to do this? And maybe there's a larger network that we're trying to work on creating to try to answer these questions that cross international borders. And so thank you very much. And thank you for letting me talk today in this wonderful meeting setup. Thank you.
Thank you so much, Dr. Sidonio. I'm a physiotherapist, and so this topic is obviously very near and dear to my heart.
Sure.
We are gonna have a couple questions, and I'm gonna start because I'm being selfish. You talked about how we can help manage or prevent some of these problems. I would advocate that potentially there's a role for physiotherapy to do education, joint monitoring. What's your opinion on that?
Yeah, I agree. One of the problems in the United States is that we've collected this joint range of motion, the HJHS, was sort of mandated and collected as part of the studies. And so now it's not mandated. And so you know what happens when you don't do this, people just stop collecting it. And I worry that we're getting a little bit, sort of lackadaisical about this. And so we're trying to encourage this. I don't think we have good guidelines on collecting this data in those with von Willebrand. Certainly, we do it every few years in hemophilia, and I think that's where people need some guidance. And maybe there would be a nice working group that can get together and sort of make some reasonable recommendations on how you should be monitoring for joint range of motion, who are the target groups, and how frequent should these be done? Because I think if you put that out there, then groups will probably, do their best to collect this data. So I agree 100%.
Oh, sorry. Is this on? Can you hear me?
Try again.
Yes.
Yeah. Just curious about your statistics on the hemarthrosis and the menstrual bleeding. When are we collecting that, like when a person has the high menstrual bleeding, do we assume that they're having hemarthrosis? Or in your data, was it a person that presents with hemarthrosis is also having heavy menstrual bleeding? Are they going hand in hand?
I mean, so that data that we've collected when we were at Vanderbilt was a cross-sectional study. So these are patients that we approached. We did uniform bleeding inventory. We did a bleeding score at that time and collected that data and then analyzed it separately. So, if you had one joint bleed, then you were part of that, 10%. Majority of those carriers had less than 3 joint bleeds there in the first 35 years of their lives. Majority of them had levels in the 30 to 50% range. So that's sort of expected, what you would typically see maybe in a very mild male with hemophilia. And so, and there's very likely, but what was interesting is when we did MRIs of those patients, we saw evidence of joint damage. We saw osteochondral cysts. We saw damage that you would typically see in a mild hemophiliac that would happen over many, many decades. And so we saw hemosiderin deposition as well. I didn't show those images, but we did see radiologic evidence of this, and we published that in a separate paper.
This will be our final question, Dr. Houston.
So the data on the osteoporosis is really interesting. What is your hypothesis about the biology there?
Yeah, that's a tough one because, and certainly you hear a lot, and maybe we hear a lot from factor companies about the direct role of factor VIII in bone health. And I think it's probably more complicated. maybe some of these patients are limited on their, their exercise and their ability to do these things. When we looked at the risk factors for osteoporosis and fractures and osteoarthritis, the carriers seem to have, and those with von Willebrand's had a higher percentage of the risk factors that are typically associated with it. And so some of it could be contribution for this. I think it's multifactorial. Inability to form thrombin, it could be a contributor to this. And I think we need to do some better studies on looking at the direct role of clotting factors. And, we don't know why at all VWF would have any role in this at all, because most of the von Willebrand patients have normal factor VIII levels. And so you wouldn't expect to see this. So we weren't really clear. We just wanted to describe it. And then we're hoping that some people in the lab will help us figure this out. So.
Thank you so much, Dr. Sidonio, for joining us today.
Yes, thank you.